All right. Good evening, friends. Thanks for joining on this VMR. Today, I'm fortunate to discuss case with Dr. Ravi Singh. It has been a long time since I met him. And last time, probably it was about 3 or 4 years ago when I was applying and we discussed lots of cases together. I remember we even did the boot camp sessions. So it was amazing. And so now it's refreshing to get back with him. I also wanted to thank Patricia for bringing the case to us. We need to help with the teaching points and Sohail to help with the scribing. So thanks to everyone who has joined. And maybe I can pass the mic to Dr. Singh.
Okay, great. Appreciate everybody coming on in these late evening hours. I'm not used to doing this late evening, but with Kirtan by my side, it's absolutely worth it. So, like Kirtan mentioned, this is I'm just so stoked. It's been a long time, and it's been just so great to follow Kirtan along with his journey. I remember when he just came on initially, long time ago, when he was applying before he even started applying on CPS, and then listen to his cases, and now see how he challenges everybody with his brain teasers every day. So I'm just very excited to see what Patricia is presenting a case today. So I'll pass the mic to Patricia and ask her to say a few words.
Okay, good evening, everybody. I'm Patricia. I am an IMG from Cameroon, hopefully a future resident. I don't know the program yet, but we'll discover in March. So today I have a sweet case for you. I hope you will like it as much as I liked it. So thank you for having me.
Sure.
Always a pleasure. Yeah.
Perfect. So yeah, whenever you, Vinny or Sohail, you guys are ready, Patricia, you can get started with the first aliquot. Thank you.
Okay, so I have 6 aliquot and the last one is the final diagnostics. So for the first aliquot, we have a 58 years old female who come to the clinic because of cough and shortness of breath. You can discuss.
Okay, let's take this first aliquot. So sort of interesting if you start building this narrative. How would I tackle this when I see this patient? So shortness of breath, very common to see. In fact, I had 2 sub-Is actually that I went over respiratory failure with this afternoon. So I did a teaching session. In that, I highlighted hypercarbic and hypoxemic respiratory failure. So that's sort of at the forefront of my mind. But then, with the cough, it's usually non-specific. So if you do a deep dive in the cough, there's many different causes. If you go by the resident's book, it'll always say think common things commonly. For instance, was a patient started on an ACE recently? So ACE inhibitors in the primary care setting, you have to think about maybe causing a side effect such as cough. And in that case, switching to ARB, we do have a large number of patients with hypertension. And ACE inhibitors are a fantastic medication, first-line medication to put patients on. Beyond that, you have to start thinking about, could this be within the time frame of maybe respiratory viruses? Could this be a post-viral cough? Could this be a inflammatory cough? So you can have certain things like GERD-related cough, upper airway cough syndrome. You can have things like non-asthmatic eosinophilic bronchitis. You can have asthma as well. Although with these things, I would anticipate a wheezing on the exam, maybe if there is asthma. With GERD, having GERD-like symptoms. So it's kind of early, but at this point, with the age, let's kind of tackle the age. Okay, so 50 years of age, you have to start thinking, what are they prone to? Are they associated immunocompromising situations? So in the history, as Patricia gives us more information, maybe that will elucidate if there's some sort of component there. But 50 years of age, when a young patient, I think infections maybe in a more geriatric patient, there can always be infections, but other sinister things like malignancies and so on. But it's quite early. I don't want to really invest too much time. What do you think? Anything there that really sparks your interest, Ketan?
No, I agree with you, Dr. Ravi, that as of now, since we are so early in the course, our job is to figure out that where is the problem lying and are both the problems related or not. So, for example, as you said, cough is something very non-specific and it could be traced to upper airways, lower airways, pleura, pericardium, irritation of any of those structures can cause it. Shortness of breath, we have a more structured approach for that. So we often say that, okay, is the problem in the lungs, problem in the heart, problem in the vasculature, problem with the diaphragm, some metabolic problems, like let's say you have acidosis, which is triggering you to breathe more and more and making you tachypneic. Is there a problem with the blood itself, like there is anemia or hyperviscosity, things like that. But the question becomes that, is the entity which is causing shortness of breath also causing the cough, or they are unrelated? Because it is not unusual to have a different cause of shortness of breath. Let's say somebody has heart failure, somebody has pulmonary hypertension, and they are presenting with shortness of breath, whereas cough is just non-specific, maybe a superimposed viral illness, which is just making things worse. Could they be related? So they could be related, because as we know that when there is increased pressure in the pulmonary vasculature, it will irritate the J receptors in the alveoli and airways, and which can trigger the cough as well. So often people who have heart failure, they can have cough only because of the heart failure itself and no other infection. So they might be related, but they may be unrelated as well. So as of now, I think our principal focus should be to figure out that where is the cough localizing, where is the shortness of breath localizing, based on the history and more HPI, and then we can try to link them together if they fit well. So I think that is what I will say. So excited to see what the next aliquot reveals, Patricia.
Okay, I love the discussion so much so far. So for the second aliquot, we have a 58 years old woman who come to the clinic because of symptom of fatigue and dry cough for the past 6 months. 3 months ago, she noticed that she got easily tired and has progressively been unable to go for her usual long walk. The shortness of breath has been more recurrent and sometimes occur at rest. That's why she decided to come to us. She denies any fever, chest pain, and vomiting.
Perfect. Patricia, I think if you have a little bit more of past medical history, that will be fine as well.
Okay. The past medical history, she hasn't seen a doctor in 8 years. We don't have any history of hypertension or diabetes. She does not have any medication. Family history, she lives in Texas, Houston. She does not have any travel history, no animal exposure. She's retired. Health history, she's a smoker for the past 15 years. She has been trying to stop, but unsuccessfully.
Perfect. Thank you so much, Patricia. So maybe I can tackle the HPI, and then I will ask Dr. Ravi to layer on that how past medical history plays the role. So as Patricia told us, that this thing is not something which is new. So we always have this thing, whether problems are acute in medicine or chronic in medicine, and depending on that, we can triage the patient and we can determine what etiologies to prioritize. In this patient, what we are seeing is that they have the symptoms for a long period of time, but lately they are progressively getting worse and worse. So what can that tell us? That is what we have to figure out. Common things being common, if the patient has exertional intolerance, like patient was able to walk 5 blocks, now can walk only 2 or 3 blocks, then the question becomes that, is the cardiac reserve getting affected? Is there some way in which heart is not able to pump as effectively as it used to? And that's why there is decreased forward flow to different organs, as well as increased congestion in different organs, both of which will lead to hypoxia at the level of organs. And that is why people feel fatigue, people feel tired. That is one easy way to look at it. But then there are other mechanisms as well. So apart from the heart, if there is something wrong with the vasculature itself, like let's say if somebody has pulmonary hypertension, then they also might present with the same kind of symptoms, that once they are trying to exert themselves, the blood flow increases to the pulmonary vasculature. And when the blood flow increases, but if the pressures in the system are very high, then again the same thing, it will dilate the blood vessels, activate the J receptors, will make you feel dyspneic. So we are not in a much different space than what we were few minutes ago. We are still handling whether it's cardiac, whether it's lung, or whether it's pulmonary vasculature. What about dry cough now? So we talk about wet cough, we talk about dry cough, and often in medical textbooks, we have this neat distinction that, you know what, if it's dry cough, then maybe it's not infectious, but that may not be true, because there are so many indolent infections, so many causes of interstitial lung diseases which can present with dry cough. So we may not be able to glean the etiology just by saying it's dry cough or wet cough, but maybe I will inquire more once I get a chance to the patient, that why things have been going downhill lately. Like, is there something changed in the diet which patient is taking. Maybe patient is drinking more water, that's why they're getting more fluid overloaded or not. Are they getting exposed to any gases or any dust substances which are making them more irritated and winded in the first place to begin with? So teasing out those details will be important. And then maybe I can ask Dr. Ravi that how we can make further progress from the past history.
Kirtan, great overview. You kind of touched on every important salient feature of this case, and I'm very interested. So this patient's coming to the clinic, so it's not the emergency room. This patient at this juncture is not in dire straits. So I don't sense any sort of hypoxic respiratory distress. I don't sense any emergency. So you see somebody in the clinic like this, okay, there's shortness of breath, but is the shortness of breath just a sensation of shortness of breath, like you mentioned, or is it secondary? I'm kind of interested. I'm going to sort of now pursue the cough for a second. So this chronic cough, what exactly is chronic cough? So cough of more than 8 weeks duration. Again, I'm going to sort of revisit the things I talked about. The past history, a patient smoked. So that's one of the first line, I guess, interventions that you do. Somebody comes, like, doc, I have a cough. Okay, maybe quit smoking, come back. Let's see if that resolves the process. Okay, patient isn't better and they come back. Also, you want to get some history. Maybe this is a post-viral cough, and you can have that for a few, maybe up to a month or a month and a half, so 6 weeks. But if it's not that, then again, you go down the line of is there an ACE inhibitor on board, which it isn't. Occasionally, you may also have a suspicion of chronic cough, upper airway cough syndrome, and there's two features of that, or two variants. One can be the allergic rhinitis associated, for which you might want to give some intranasal decongestant at that point and see if it improves. So you usually give something like a first-gen antihistamine and decongestant, and then see if that resolves the process. Patient comes back is not any better. Could there be asthma involved as well? We haven't gone to the physical exam, but if there's wheezing, that might actually give you an insight into this possibly being the cause. So what would you do in that case? It can be a very good board exam question. So send the patient for spirometry and also test for bronchial hyperresponsiveness. And then at that point, you might have to give some inhaled glucocorticoids. Then there's this thing about non-asthmatic eosinophilic bronchitis. So usually you may, if you have an exam question, I've seen these questions because I do board review, and you may get sputum with eosinophils, and that might clue you into this. So you may also want to give therapy with inhaled glucocorticoids. When you get to a point where it's none of these and you've gone down the process, and this is also a long stretch out process, and the patient, of course, is going to be stable, but this patient, we still don't know, is this patient going to be devastatingly sick and we have to then transfer them to the emergency room, or is just something we can tackle in the outpatient clinic? So cough without acute cause, you have to think about GERD, right? So giving a trial of PPI might actually be helpful or beneficial in that case. And this is what I see in the outpatient clinic. The common garden variety cough, maybe you get some shortness of breath with that, and it's tackled in this way. But if this patient is devastatingly sick, of course, we have to switch gears and start working them up, and then doing imaging, and so getting also CBC chemistry if they're really hypoxemic, getting a blood gas, and then seeing what you have. But at this juncture, I don't know, the smoking does have a role to play, but I'm not getting any signal here to really, no alarm features at this point, I could say, right? The vital signs haven't been given, but at this point, I would kind of overlap cough with this shortness of breath and see what we have. Smoking could give you some insight into maybe something in the background. Is there maybe smoking related ramifications, COPD, asthma overlap? Could there be more nefarious or complications of smoking, cancer at this point? But there's nothing like no weight loss, no hemoptysis, nothing there to really signal this. So at this point, I still don't know. Another feature of lung malignancy could be frequent lung infections due to intrabronchial lesion that could be closing up the airway and causing recurrent infections. But we're not getting even a signal for pneumonia. No fevers, no cough, no like junky phlegm, no funky inflammation or anything like that's present here. So I think we need more information before we can make progress.
Yeah,
back to you,
I
Patricia.
yeah, I agree with you, Dr. Ravi, that it's a wide open. And as you were saying, that smoking may not be linked directly, it may be linked indirectly. So let's say if somebody has malignancy, like a mediastinal pathology, and that mediastinal pathology is compressing on the surrounding structures, and often you could imagine that how if it is progressively enlarging, it might cause shortness of breath, it might cause cough as well. But again, all of this is very similar to heart failure or ILD or pulmonary hypertension. Like there is nothing in the exam which might clue you in. So let's see what we find.
Very interesting. I'm just going to sort of use what you mentioned there. And actually, we had a very good ALA case yesterday, just using that abbreviation, where a patient was sick for quite some time, but had a enclosed in, what do you call it? I don't want to give the diagnosis, but something that was sort of sinister and bubbling under the surface, and you can have those kind of things. The other thing we had earlier on mentioned was immunocompromised status. If this patient is immunocompromised or not, then it sort of opens the door to certain infections, so PJP, fungal infections, TB, and then this patient is out in Texas, I think. So what can you, it's sort of like a vignette for a step 2 question, right? Patients in Texas, what can you get? They come with shortness of breath, or it could be hantavirus. It could be one of those kind of viruses out there. It could be coccidio. So we still don't have any signal for that, but I think keep it on the back burner. This is about to get interesting, I think.
Patricia, you can go ahead.
Okay, thank you. So for the vitals, temperature, blood pressure, everything is normal. General appearance, she's not acutely ill. As we mentioned, we are seeing her in the clinic. So she talks, she expressed her concern, but she looks fine. For the ENT, it's normal. The cardiac examination, no murmur. Pulmonary examination, we found inspiratory rare on both sides of the lungs. And the extremities, we noticed digital clubbing of the fingers in both hands, but the lower extremities looks normal. For the lab, we don't have much except for hemoglobin at 8 and with an MCV at 88. Sodium, potassium are all within normal range. Thank you.
Dr. Singh, you can go first. Yeah.
Okay. So seek and you shall find, as they say. So Kirtan, I think we do have probably not the major pivot point, but we have a few pivotal points, which now we can make progress on. So I'm going to tackle one of them. Let's just kind of have fun here. So the inspiratory rails. So there definitely is signal in the lungs. And so these rails could be anything actually. And usually rails would be anything in the, if say you take the airway, you'd mention, okay, dyspnea can be anywhere along the bronchial tree, tracheobronchial tree, you can say. So tracheitis, bronchitis, tracheobronchitis, pneumonia, bronchiectasis, any number of these different things. But I think you would anticipate more wheezing or musical components. Now you're just hearing rails. So I think we're at the level of the alveolar. So some things within the alveolar, could it be dry material? Could it be cells? Could it be malignancy? Could it be just debris? Could it be inflammatory exudate? I'm not sure. But what could really pull the covers off this would be, say, a honking big white count. I don't have a fever. The white cells, the vital signs are normal. And then Patricia also said the patient looks fine, but you have this abnormal lung finding. So I am thinking less sort of acute infection, maybe something that's more chronic. So you mentioned inflammation before, so maybe something fibrotic in nature. But I think imaging, this should key you into doing some imaging to push the needle forward. You want to tackle this clubbing? This is also very interesting.
Yeah, sure, Dr. Singh, I agree with you then. And maybe I can try to link what you said and then figure out then if we can explain the clubbing or not. So, friends, as we know, what is clubbing? Clubbing is something known as hypertrophic osteoarthropathy. Basically, it means that there is expansion of the distal aspects of the osteoarticular structures. So it's not just the finger pulps or the digital pulps, but it also the underlying structure. So the bone itself, the periosteum becomes hypertrophied, and that's why sometimes people feel the pain, irritation in the extremities, along with the classical clubbing appearance of the nails that we see. And there are various pathogenesis which can cause it, and some of those are not clear. But one common denominator is that it has got to do something with the release of growth factors like platelet-derived growth factor or fibroblast growth factors from the platelet particles. And why these growth factors are being released from platelet particles? Because they are being sheared at the levels of pulmonary vasculature because of the hypoxia, or something is wrong with the way they are moving through the pulmonary vasculature. So we can try to tackle that what are the common causes of clubbing, and then we can see if it fits with the inspiratory rails and this progressive worsening shortness of breath that patient has been experiencing. So most common cause of ILD are the pulmonary causes, and in the pulmonary bucket, the big one is the interstitial lung disease. So as Dr. Singh was saying, that is there something fibrotic cooking on? Now, in general, when people have fibrotic lung diseases, we tend to hear the Velcro-like crackles, which is the classic description. But again, you could imagine that what is the sensitivity of these findings? Not that much, and it's also observer dependent. It's also dependent on how progressive your condition is. So maybe if you are catching it so early, you may not find crackles and all the classic examination findings. But interstitial lung disease is something which is important to keep in mind. And if we go down that rabbit hole, then you start wondering that what can cause interstitial lung disease in a 58-year-old lady. So, and can smoking do it? Definitely. Smoking is known to promote the fibrosis and COPD together. It can cause usual interstitial pneumonia. It can cause non-specific interstitial pneumonia. And there are specific ILDs associated with smoking as well. Like people can have follicular bronchitis, people can have respiratory bronchiolitis associated ILD, desquamative pneumonitis, and all of them have different patterns, whether they're in upper lobes, whether they're in lower lobes. So based on the imaging, we can kind of figure out where it is going. And then in a lady, you always want to worry about the connective tissue diseases as well. Like is there is mixed connective tissue disease, is there is lupus, Sjogren's, sarcoid. So all the CTDs can cause the ILD as well. So that is one big bucket. Second is bronchiectasis. Now, Dr. Singh was telling us earlier that if somebody has recurrent infections, then that might be a clue that something is wrong with their bronchioles. And bronchiectasis usually presents with recurrent bouts of infection, and bronchiectasis can lead to clubbing. Now, bronchiectasis has its own set of differentials, but we don't have that flavor yet of because usually people produce like productive sputum, very thick in nature because of mucus hypersecretion, which we don't have. So dry cough goes more with the ILD kind of situation. The third, more sinister bucket is the pulmonary malignancies. So people can have small cell lung cancer, squamous cell lung cancer, adenocarcinomas. Usually adenocarcinomas are more associated with the clubbing. And it will be interesting to know that where is adenocarcinoma? Is it in the airways? Is it in the mediastinum? Is it abutting the pleural surface or not? That is the third bucket. There are other causes outside of lungs. So people can have GI problems, but in our case, so far, we do not have a GI signature. We don't have hematochezia. We don't have weight loss. We don't have malabsorptive symptoms, no abdominal pain. So GI tract malignancies and malabsorptive disorders are lower on the differentials. Patricia said that there is no clubbing in the lower extremities. And maybe I will ask Dr. Singh to comment on that later, that what are his thoughts on this. But usually it is other way around, as far as I know, because there are many conditions in which you could have a problem at the level of ascending or descending aorta. So let's say people can have coarctation of aorta. People can have patent ductus arteriosus, in which the oxygenated blood to the lower extremities is compromised. Upper extremities are served well, but because of the coarctation, maybe the lower extremities are not getting enough oxygen. So often you might find clubbing in lower extremities. So that is also known as differential clubbing, which means you have clubbing in lower extremities, but not in upper extremities. In our case, it's other way around. It's in upper extremities. And honestly speaking, all these disorders are so heterogeneous that I have seen so many people who literally have clubbing in 5 fingers on one hand and 3 fingers on other hand, and then you start going into this rabbit hole that, oh, what if there is a vascular stenosis in one arm and stuff. But to be honest, that is seen only in rare cases. In ideal world, you can have clubbing in whichever proportion it's possible. So unless you have clear evidence that somebody has hypoxia, cyanosis, or coarctation of aorta, there is not much to glean into based on where is the clubbing present. But the important thing is that there is clubbing present. So as of now, where am I standing right now? My biggest concern is that maybe this person has ILD, which can explain the rails, dry cough, and probably ILD could have also led to the pulmonary hypertension, which could explain this progressive exertional worsening. And the other thing which I would like to rule out, because it's sinister, will be the malignancies. So what do you think, Dr. Singh? What do you make of clubbing? How do you link it?
Oh, I'm just in awe of you waxing lyrical about clubbing. You just were able to just extract so much from this finding. So that's why I kind of explained it. It's a major pivotal finding, and when you marry it with the lung findings, I think you're in the bucket. Like you did such a nice job with outlining all the different causes, going through this journey of GI, about biliary disease and so on. But here we don't have any signal for that. So the lungs is back to the lungs. So that's where the problem is. And that's where we need to find a problem. So at a point, I would put a pin in it and I would then just put it on the board and just sit back and see what else we can put with it. But I think you did a wonderful job. Now, the lower extremity clubbing is very rare. It's just remarkable you were able to remember PDA causing it. I don't think I've ever seen a case of it, but I want to give you kudos for at least exploring that and discussing it and teaching everybody about it. So wonderful job there. All right, back to you, Patricia.
Wow, I have so many teaching points from you. Thank you. So, for the sake of discussion, we hold on to one information. I don't know how you will analyze it, but this is it. So our patient was diagnosed with rheumatoid arthritis 8 years ago, but she's not on any treatment, and she's really vague about how she got diagnosed. I don't have the CT scan, but I have the interpretation. I don't know if you want me to give it now or wait.
You can give us, Patricia, yeah.
Okay, so the CT scan, the interpretation was, no, I have the feeling that if I give you the interpretation of the
You can wait, Patricia. I mean, if you have imaging, you can share with us. Do you
all
have
right. So the CT scan show that it was a typical usual interstitial pneumonia pattern with honeycombing, multiple cystic lesion within the lung parenchyma due to fibrosis. There's also irregular thickening of the intralobular septa with ground glass opacity.
Perfect.
So this is interesting, right? We kind of thought about it. We have this information now. This rheumatoid arthritis really takes it up a notch. Remember, I said get ready for the ride of your, well, it's not really ride of your life, but it's really going to get interesting. So this is exactly what I was kind of anticipating. So Patricia mentioned with RA, we were thinking about something in the lung which could be inflammatory, and lo and behold, you have a major autoimmune disease. Now the problem here is, was this diagnosed appropriately? Did they go down the route of doing all the usual antibody tests, or was it just a preliminary diagnosis? Oh, it kind of looks like this. I don't get any signal for this patient having any. Now, what is the hallmark of rheumatoid arthritis? Usually you'll have patient with small joint disease, mainly the hands. It's symmetrical, and you have synovitis. Usually, yeah, again, symmetrical. There's early AM joint stiffness. And then I don't see anything about the antibodies. So if there's any history that that Patricia can give us for maybe rheumatoid factor, anti-CCP, SED rate, CRP, and usually the SED rate, CRP will be elevated in acute exacerbations of this condition. So I am kind of interested to see, and it's a multi-system autoinflammatory condition. So it's not usually just lung, although that could be an early manifestation. But I would kind of like to see manifestations. You can get anything from ocular, oral, skin, pulmonary, cardiac, and so on. And then also the hematological system. But here we just have the hemoglobin we don't have any sort of cytopenia or any problem there. But ILD is a hallmark of rheumatoid arthritis. But what do you think at this juncture, Ketan?
Yeah, I agree with you, Dr. Singh, that we were thinking about some connective tissue disease which can link the ILD and clubbing. And now we have possible evidence of that. But as you were saying, that it's very important not to anchor. Often, many times what happens that people will have random arthritis and they will be labeled as rheumatoid arthritis. So you do want to go back in the chart. You do want to examine the patient. that where are the joint inflammation? Like, okay, if the patient tells me that there is pain in the hips, pain in the back, and then that's not a good story for RA, right? Because every arthritis has a specific joints which are involved. So in RA, I would more interested in checking their fingers, checking their digits, making sure there is no inflammation there, checking their wrist. And even if not now, maybe in the past, if there was any evidence of inflammation in the fingers or not. Now, this connection between the CTDs and ILDs is very interesting because we need to figure out the tempo of the illness. Often, what could happen is that people can have ILD as the first presentation of RA, and they might not have any arthritis symptoms. And it is easy to get fooled that, oh, this person doesn't have arthritis, so how can they have RA? But it is possible that they might develop RA few months down the line, or they might have arthritis symptoms few years down the line. So this is always important to realize that connective tissue diseases can evolve, and depending on which disease you are talking about, like often it happens in people with antisynthetase syndrome and dermatomyositis, often the ILD is the predominating and the chief symptom. They may not have rash, they may not have myositis. All they have is ILD. So it's important to understand that how diseases can evolve. But still, having said that, we know that this person has been diagnosed with RA since 8 years. So if we truly believe that this was true RA, RF positive, CCP positive, clear joint involvement, then you might wonder that why does the person has no other symptoms yet, like no cutaneous nodulosis, no pleuritis, which is classically seen. Not to say that you need to have all of this to have RA associated ILD, but usually the dictum suggests that the longer the RA you have, the more likely it is that you will accumulate other organ damages, and ILD happens to be one of them. And often these things are missed on examination. So maybe we can ask Patricia that if we go back to the patient's bedside, we do a thorough examination of their skin to look for any nodules anywhere. We can look for synovial inflammation anywhere. We can look at the imaging. We can tease apart if there is any evidence of pleural effusion, because all of these are common manifestations of rheumatoid arthritis. Now, let's say if we get RFCCP and they are negative, then what would we do? Like, would we try to figure out other connective tissue diseases like getting ANA, getting ANCA, getting myositis panel? So I think that is a reasonable step, given that we are dealing with a lady, which are, so CTDs in general are more common in females, and it can present with ILDs as well. But I agree with Dr. Singh. The first job is to tease apart whether it's RA or not. So what do you think, Dr. Singh? What can
Yeah,
we do as the best next step?
wonderful. It's just having such a great time just discussing with you, because when I hear you talk, it triggers certain things. It's just sometimes very difficult to collectively put your thoughts together, and you want to say so much, but sometimes it's just like you're saying one thing and you forget other things there. But you hit a really important point. This is 8 years of RA. You cannot just have lung involvement. There has to be other manifestations. And with RA, there's always this signal of the synovitis, especially in the small joints, so the hands. What is a key feature on the hands is there's lack of involvement of the DIP joints. So usually we'll have the hands. You'll also have the wrists. You'll have the knees. You have the hips, and you spare the atlantic or axial joint and so on. So not the spine. There won't be anything in the spine. So I definitely would look for any joint involvement, and then look for at least hematological signals. So at least the CCP, RF. Can you get, so if you're not in an active phase, could they be positive? Maybe not. At least the SED rate. I would start with the SED rate and CRP. And as Jas had mentioned a while back, we had a VMR. We had SED rate, CRP elevated. So you have to think about which one is, when one is elevated and the other one isn't. One can be a signal for acute inflammation, one for chronic. So I at least want to get some more data and see, could this be a mixed connective tissue disease? Could be. But I really want to go back and survey the charts to see who made this diagnosis and under what kind of basis did they make this diagnosis.
Perfect. Dr. Singh, any, since I think we have enough time and maybe Patricia is nearing the end, so maybe we can spend some time that, what are your thoughts on these cystic lesions? Like, do you think it is just related to ILD? Because we know ILD can cause tiny cystic lesions, or it could be something else. Like, how is your approach to that, Dr. Singh?
Yeah, I can't really recall a great approach. There's a lot of inflammation in the lung. Honeycombing usually is the end of cycles and cycles of inflammation. So honeycombing will be, or have that that typical Velcro sound that you mentioned. So when you hear it, you don't forget it. And with this much honeycombing, I would anticipate this patient, the alveolar, pretty much the DLCO is low. If you do pulmonary function test, DLCO is going to be very low because you got that much honeycombing. So I'm kind of surprised that the patient may be compensating and is able and smoking as well. On top of that, I would think this patient would be hypoxemic and very symptomatic, but this patient looking well and compensating and not even tachypnic or using accessory muscles or anything like that. But these cystic lesions, to me, I really would like to take a look at the image to see if this is the cysts due to cycles of inflammation and destruction. So could there be cysts from an area where there's void of any tissue? Are the cysts due to something depositing within the lung? Are they due to excess deposition of tissue and forming these cysts? So a number of mechanisms where these cysts can occur. Certain infections can cause cystic-like manifestations, or inflammations like LAM can cause these cysts all over the lung. But we're not getting this kind of favor. LAM's not going to give you honeycombing to this degree. So I think I don't know what would be your approach to cystic lung disease if you do have one.
No, I think Dr. Singh, I agree with you that. I mean, we are trying to, beat the bush out of it, but at the end of the day, you need to figure out that what's the location, right? I mean, if we say that this is just in the basal regions and related to the ILD, then maybe it's just due to the traction and cycles of inflammation. But unless it is florid and it is present all over the lungs or in locations which are atypical, then maybe we could probe deep. And also regarding the septal thickening and GGOs, now we often learn in medicine that UIP pattern has these features, NSIP has these features. But the truth is that when you reach the end stage of all the diseases, it's kind of like heart failure, that eventually everything can cause dilated cardiomyopathy, right? It's the end path. So same way, so many inflammatory diseases in the lungs, whether it's infectious, malignancy, neoplastic, whatever, eventually it can cause septal thickening, GGOs. So it's hard to figure out. But given the fact that patient is a smoker, and we know that people with smoking and RA have heightened risk of malignancies. And as Dr. Singh was telling earlier, deposition, right? So often people can have bronchoalveolar carcinomas, lymphangitic carcinomatosis, and all these things are known to cause septal thickening as well. So maybe we can seek the help from radiologists in such cases. That do you think that the septal thickening that we are seeing is proportional to what you will expect in somebody with ILD? And if they say that it is out of proportion, like too much septal thickening, too much GGOs to be from UIP, then maybe you can start exploring other deposition diseases, classically malignancy in this case. So excited to hear more, Patricia, that what do you have regarding ESR, CRP, RF, CCP, any of those data?
Okay, so when the patient came, we were actually in the setting of pulmonology clinic. So when my attending saw the report from the CT scan, he diagnosed that it was indeed interstitial lung disease. So we were looking for a cause. So we asked for what you asked for CRP, ESR, rheumatoid factor, and anti-CCP. But unfortunately, I couldn't have the exact data. So she went and we noticed that it was elevated. Like I got the result later and sorry. I got the result later and all those value was elevated. So she indeed had rheumatoid arthritis. So me and my attendant, we conclude that the patient have connective tissue disease, interstitial lung disease. Yeah.
Oh wow! So with seeing this patient, the RA wasn't that the history was kept from you until later.
Yes, sir.
Oh wow! Again, this is another VMR where in real time, as this case is presented, is so important to get history. Without that history, you can't make progress. You could potentially, but there was no signal outside the lung for RA. And I've never seen a case where RA would just manifest with the lung, but like you said, it could happen. Excellent case. Thank you.
Yeah. So Patricia, like even when we went back and asked the patient, they never had joint symptoms.
For rheumatoid arthritis.
Yeah, like any kind of joint symptoms at
Oh,
all.
they had. She was also complaining about pain in her joints. That's how she got to the rheumatologist. But we did not have any paper, anything to confirm her diagnosis. She was also very vague. But her husband was saying that okay, she's been followed by a rheumatologist, but she was not like consistent. So us, when we saw her, we asked for like for the lab just to confirm that she indeed have rheumatoid arthritis, because her history was not really clear, and my attending wanted to make sure that okay, that's the source of her interstitial lung disease.
Yeah, that's good to know. Thank you so much, Patricia. And do you have any information as to what kind of treatments you guys pursued and how is the patient
Yeah.
doing now?
So we asked for the lab to confirm the rheumatoid arthritis. We sent her to a rheumatologist. We also wanted to do, like, my attending surgeons to do a bronchoalveolar biopsy to confirm her interstitial lung disease, and to start treatment on steroid and maybe antifibrotic agent. And from this case, I was also like, I knew from both that okay, connective tissue disease can give you interstitial lung disease, but it was my first time seeing it. And from the literature, it was it was actually interesting to know that like approximately 10% of patients with rheumatoid arthritis can develop interstitial lung disease, and sometimes interstitial lung disease can happen before the symptoms of rheumatoid arthritis. In some article, they were like maybe 5 to 10 years before they have any symptom of rheumatoid arthritis. That part I didn't know, so it was really interesting for me to learn from her. And with that much of looking at her city was really was not good. But when you look at her, she was not in acute distress. She was, yes, she was complaining that she's not feeling well, but it's not the kind of not feeling well that you are laying on the bed, you know. She was breathing on normal hair, and yeah, all of that was actually interesting.
Wow, thank you so much for great teaching points, Patricia. And before I make the final comments and ask Dr. Singh to also chime, I wanted to highlight the chat as well, since we have enough time, I guess, today, that everybody in the chat, like Mark, Yusuf, Anmol, all of them mentioned beautiful thoughts that the patterns of ILD, how it is important. Like Mark was mentioning that UIP is something which is more common in RA compared to other connective tissue diseases, so which is also important, a good way to figure out that a good way to predict, I would say, to say which connective tissue disease could present with this pattern. So which was good. So thanks for participation in the chat, friends. And yes, I agree with you, Patricia, that the treatment is very critical, because the UIP is such a morbid diagnosis that we see the patients in the hospital day in and day out. They keep on coming with this increased hypoxia, and there is no way out of this. Like even if we give antifibrotic therapy, sometimes people don't turn around. So the timely intervention is very important. And maybe I will share one of the glass health schemes that I have learned from other people, that how do you treat ILD effectively. So there are two things which are very important. The first is to figure out if there is fibrosis or not. If there is fibrosis, then regardless of what ILD led to it, the treatment is same. You have to go with the nintedanib and you have to go with the perfenadone, the two antifibrotic agents which Patricia was mentioning about. So in this case, given the fact that we have significant honeycombing, there is enough evidence that there is significant degree of fibrosis. So regardless of whether it's RA or not RA, we should give these antifibrotic agents. The second aspect is, what if it is indeed CTD associated ILDs? Then what do you give in those scenarios? So different agents have been tried, but the best evidence has been for mycophenolate mofetil and for cyclophosphamide. And often in earlier phases of inflammation, before the fibrosis sets in, if you give these agents, then there is some evidence that maybe you delay the progression of ILD. You may not have mortality benefit, but you will delay the progression. And the reason why I'm mentioning this, because Patricia mentioned in the CT scan, there were some GGOs. Now, this is important because the fact that you have GGOs means that there is some degree of inflammation. In fact, most of the people who have so-called fibrotic ILD, like UIP, if they come to the hospital and they have some GGO scattered over the background of honeycombing, that's an evidence that you are dealing with something known as acute exacerbation of ILD. It's similar to how you have acute exacerbation of COPD and how you get wheezing and everything. So when ILD exacerbates, often what you see is GGOs, and that gives you a clue that maybe there is a window of opportunity where you can dampen the inflammation and hopefully prevent the further fibrosis. So in such scenarios, it is very important to have multidisciplinary discussion with the rheumatologists and pulmonologists that, hey, do you think that if we give MMF or cyclophosphamide, it will prevent the progression in some way or not? So that is the key aspect to figure out. What do you think, Dr. Singh? How has been your experience with treating such ILDs?
Oh, wonderful. Yeah, I'm not one to treat, but it's very difficult. By the time, see, what Patricia is describing a patient in the clinic, so you have time. And the hallmark usually of what we group all of these features or these lung inflammatory conditions is diffuse parenchymal lung disease, so DPLD. And what's interesting is they usually will come with a normal oxygen saturation. So one thing what I've learned is you could do is though they're compensating, but when you walk them, they do then have a decrease in the oxygen saturation. So even though they're at rest, they have normal oxygen saturation. You're like, okay, the vital signs are normal. Try walking them, and you actually may see a desaturation, usually beyond 4 or 5%, which could give it away. But from what in trying to go back to this patient, trying to figure out when you have DPLDs, you usually think about exposures, and you also then think about inflammatory sort of DPLDs in that case that don't have exposures. So you talk about patients that have some sort of like occupations, patients that could be hobbyists and using some materials that could trigger DPLD. Medications like amiodarone, we have smoking, certain other medications that can cause pneumonitis and things like that. And the workup usually would have to be, of course, getting a high resolution CT, but then also doing serological testing. So we mentioned CRP, we mentioned ESR. I think also getting the ANA rheumatoid factor in this case, myositis panel, and the anti-CCP is recommended. What we recommend when working up a patient like this. So these are the standard pulmonary battery of tests that you will get for somebody like this. So get the imaging and then get the CRP, ANA, and so on. And then one of those may actually light up and be abnormal. And that hence would give you the diagnosis. So here, I think that will be helpful. There is one more step where you could do a lung biopsy if you can't find a reason for this DPLD in this case. But those are the steps that I usually would do and what I've learned. And I think if I had this patient in the clinic, unfortunately this patient was compensating and doing well. I really hope they do respond to treatment. Patricia, do you know how they did after therapy? Kirtan went over the fabulous steps of therapy that can be implemented.
Sorry, I did not have I was not able to get any feedback after.
But yeah, but usually by the time I've seen them in the hospital, though, when I've seen them, it's end stage, it's too late. They end up in IMC, ICU, mechanical ventilation, or before that, they may have to go on BiPAP or high flow nasal cannula. The oxygen requirements are so vast, and it's very difficult. You treat them with a concoction of steroids, high dose steroids. Sometimes a superimposed infection. You have to treat them with antibiotics, with high dose steroids, antifungals, maybe sometimes because of immunocompromised status. But the outcomes usually are very poor. If we can implement a palliative care approach, that is always helpful.
Yeah. Thank you for sharing your approach, Dr. Singh. And yeah, thank you, Patricia, for amazing case. It's a reminder that how you have to keep on seeking the answers in the history itself. And this is also a very good case of, like how Ravi likes to recreate the story. So if you could imagine that you see a smoker and you see them in the hospital clinic and you see their nails and you see the clubbing, what's the first thing that would come to your mind? Kind of like that, because often people have this misconception that COPD causes clubbing, but actually that's not true. Like neither chronic bronchitis or neither emphysema by itself in pure form would lead to clubbing. So often whenever I see in clinic people who are smoking and they have clubbing, then often I get alarmed more because I know that The clubbing itself implies that probably it's not COPD which is driving this. It's something more sinister, either a malignancy sitting there from smoking or the ILD as in our case. So such a humble reminder that how small things can make you go all the way through and can lead you to go away from all these anchoring biases and red herrings. So thank you so much. Thank you, Dr. Singh. It was always a pleasure to discuss with you again. And as you rightly said, it's the triggering that sometimes
Yeah,
you speak something and then I get the spark and the vice versa. So it's so
yeah.
good. Yeah.
Kirtan, and it was interesting. The first time we discussed, or one of the times we discussed together, was a patient with ear pain, which was relapsing polychondritis. So what did we do? We put
Yeah.
all of our thoughts together and made a schema. So I would do something together with you
Yes.
for clubbing. I
Perfect.
think the clubbing was a great discussion. Let's do that.
We'll do it.
Right.
Thank you so much, Dr. Singh. And thanks to Sohail for helping with the scribing. And now I already see amazing teaching points by Vinny. So Vinny, you can take us home.
Yeah. So basically, I will start with the discussion was mainly about a patient that presented with shortness of breath and cough. And this is very non-specific. It can present with a wide variety of causes and clinical manifestations. And the first thing that we need to know is this is hypercarbic or hypoxic. And then the tempo would help us to differentiate if this is a chronic or a acute cough, in being the chronic cough more than 8 weeks. And we'll need to study the associated symptoms that the patient has meanwhile. Besides hypertension is another thing that we can proceed with the investigation if there is any kind of pulmonary edema or any introduction to ACE inhibitors or any viruses or even post-viral cough or inflammatory causes that can be precipitating the clinical symptoms. GERD is another possibility. And then we'll proceed with an anatomic investigation if this is related to the upper airway, to the lower airway. If we have like heart related or lung related, if this could be cardiac ejection fraction, the congestive heart failure with varying grades of ejection fraction, if this could be endocarditis. And when we think about lung, this is a possibility of pulmonary hypertension, or this will be a problem of the sinuses or the trachea, bronchiectasis, or even tracheobronchitis, tracheitis, the bronchioles, or finally the alveoli. And when we see the physical examination, if we find something suspicious in the alveoli, we need to imagine what could be there. Could be there any kind of dry material, any debris, inflammatory exudate, or malignancy. And finally, if this could be a problem of the vessels also. And then we'll see if the patient has exertion intolerance. And Kirtan told us that this could be intimately related to the activation of the J receptors and could cause an overload congestive situation and precipitate a lot of clinical symptoms. And then we'll see if the heart is not pumping, if this is a problem of the right ventricle or the left ventricle, or even dilated cardiomyopathy. Besides, we can see that the extracardiac causes can be compressing the heart. And when we think about the lung, this is an interstitial lung diseases. If the age of the patient will be important to investigate here. If we have COPD or exposure such as gases, smoke, or toxins. If the patient has clinical symptomatology of allergic rhinitis, the patient already had used any kind of antihistamine or any decongestant use. If this could be malignancy, and it's very important to investigate the immune status of the patient. So the first steps that we'll see about the clinical management is the oximetry As the patient is in an ambulatory setting, we will proceed with the spirometry. We can start inhaled corticoids and can also do a trial of PPI due to investigation of GERD, and imaging with high resolution CT will be essential here. Then, if the patient has any suspicions of autoimmune diseases, we can proceed with ANA or antibodies, and CBC will help us also blood gases. Then we can differentiate if this is a eosinophilic predominance or neutrophilic predominance. But the main takeaway that of the entire session is about the clubbing, and we discussed in that extensively. We investigate the club related to chronic pulmonary infections such as hypertrophic osteoarthropathy. That is a clinical manifestation that would affect the finger, bones, periosteum, and causing inflammation and cursing in conjunction with arthralgia and possibly skin changes. This is related to the release of the fibroblast growth factor of the platelets that is intimately related to hypoxia and local remodeling. And then the first thing that will proceed with the investigation of clubbing is idiopathic pulmonary fibrosis and interstitial lung diseases. We can find Velcro on physical exam, but this is not sensitive. It has not a big sensitivity, and it is not also specific. And will also correlate with possible causes related to smoke or even non-specific interstitial pneumonia that is related intimately with lupus, Sjogren's, sarcoidosis, polymyositis, and dermatomyositis. We can also have drug-induced lung diseases and even idiopathic causes. So in the second bucket, we have bronchiectasis that can present with clubbing and productive sputum, hemoptysis, and finally, in the third bucket, we have malignancy. And we have a wide range of different malignancies, and we have our different diagnoses such as GI tract and malabsorptive disorders. So Kirtan also made a point of the correctation of the aorta that will manifest with clubbing just on the lower extremities, but this is very rare. And other vascular stenosis can cause other pattern of clubbings that is not unilateral or presents with a specific pattern. Then we went to the mood system inflammatory condition that our patient presented with a mood system inflammatory condition, and we could relate that to rheumatoid arthritis, and she also had a synovitis, stiffness, and lack of involvement of distal interphalangeal joints. So we will see if the CRP or the ESR is elevated, and even if this could be a mixed connective tissue disease. And finally, we studied about the cystic lesions and their relation with interstitial lung diseases. So we discussed about the honeycombing pattern, the GGOs, and the possible of septal thickening, that the DLCO will present as low in the respiratory function, also reduced lung volumes, the forced vital capacity, the total lung capacity. This is related to the cycles of inflammation and destruction. And basically the treatment of interstitial lung disease associated with autoimmune diseases such as rheumatoid arthritis is a challenging one. You can proceed with high steroids, even cyclophosphamide and escalate steps, and use whatever you need.
Perfect. Thank you so much, Vinny, for very comprehensive reading points. It's probably the first time that we did such comprehensive reading points and are ending at the right time as well. So thank you so much, everyone, for joining. Thanks to Patricia again. Thanks to Dr. Singh for guiding me. And thanks to Vinny and Sohil for crafting the whiteboard. Thank you, guys.
Thank you. Have a good night.